So my talk is on cemented hip replacements in dysplastic hips. And rather than give you a theory-based talk covering the evidence, what I thought is we'll cover some of the cases that we have done at Wrightington Hospital and show to you what our philosophy is in managing these difficult patients. I've divided the talk basically into the 4 clinical questions that I always ask myself when I'm doing a dysplastic hip. Where am I going to put the hip center? How am I going to handle the acetabulum? What am I going to do to the femur? And then we will try and see this with some cases. All of you are familiar with the classification systems of hip dysplasia. We know the Crow classification, which divides the level of the position of the head into percentages, into 4 types, varying from subluxation to a complete high dislocation. I personally find the Arthroplasty classification more useful in terms of management because it forces me to think about the actual pathology that is present inside the hip joint. So in a dysplasia, you have practically the femoral head sitting where it should sit, and whatever your preferences of doing a primary hip replacement, usually those strategies work. Whereas in low dislocations and high dislocations, you have to try and figure out where you're going to put your femoral head center. And in high dislocations, sometimes you have to additionally think of a subtrochanteric shortening. The acetabulum is often quite small in a high dislocation, and it is more often than not like a small triangular piece of bone. So where do we place the hip center? My personal preference is to place it as anatomic as possible. This gives you a better biomechanics, abductor lever arm, leg length, and offset. Therefore, you get a better gait and better function. It allows you to restore the bone stock for the next procedure by using autografting, and therefore it has good long-term results. And at Wrightington, we do believe that every primary that should be done is a physiological primary. You have to try and restore the bone stock for the next operation. But what is the concern in bringing the hip center down? It can be technically a difficult operation. The soft tissues are quite tight in a dysplastic hip, and you have to do extensive releases to bring them down. Lengthening can be a problem if it stretches the sciatic and the femoral nerves. And once you bring it down, you notice that the superior acetabular bone is often missing, and you have to reconstruct that with some technique that works in your hands. If you do have to go for a high hip center, the literature suggests that there can be problems with this philosophy. The bone stock is usually inferior, higher up in the pelvis. You've got greater shear loads, as a result of which you get more loading, eccentrically, poor gait, length, and abductor function. If it's a unilateral problem, you might end up with a limp if the femur has not been lengthened already in the past, and you may have to choose extra long neck prosthesis, which can cause impingement and dislocation. This nice paper from Pagnano and another paper from Hirakawa showed that so long as your cup is in the true acetabular region, you are likely to get good results, and they reported about 40% loosening between 15 to 20 years. Whereas if the cup is outside the true acetabulum region, the loosening risk is much higher. So how do we deal with the acetabulum? So my preference is to use an autograft of the femoral head. So let's talk through the 3 levels of the Arthroplasty type of cases. So this case is probably the mildest variant, where your femoral head is nearly in the acetabulum. A lot of you might use an uncemented cup and leave the cup slightly uncovered superiorly, and that philosophy works quite well. My preference is to use a cemented cup and to try and get it nicely covered to restore the bone stock. Use a structural femoral head autograft and fix it with screws. And what we found at Wrightington at about 15 years, 70 to 75% of these bone grafts are doing quite well. And when you go in for revision surgery, you get better bone stock in the acetabulum. The unloaded portion of the bone graft does tend to resorb with time. Now this is slightly more severe. It's a low dislocation. The principle is the same again. Try and restore the bone stock using a femoral head autograft. So this is the way you can plan the case. With digital templating, or if you have got the old-fashioned paper templating, that is also fine. Try and figure out where the teardrop is and where the cup is going to sit, and then try and figure out how your femoral head autograft is going to go, how the screw positions are, and the problems with any femoral canal. 3D CT and reconstructions are quite helpful, and in complex cases, I do obtain them. I like to do CT scan planning in the axial sections and in the coronal sections also, because they help you measure the diameter of the acetabulum in the AP plane, and that helps you determine what the size of the socket is going to be. It also helps you in determining leg length. Sometimes when the femur has been lengthened in the past during pediatric age group, then you can have a problem because the femoral head might be high, but the knee joint is at the same level because of femoral lengthening. In these difficult cases, I find advanced planning using sophisticated software that is commercially available quite helpful, because it helps you to determine the leg length. We don't quite know how much is safe to lengthen, and there are papers suggesting that between 2.5 to 4.5 centimeter lengthening has been achieved, beyond which they have noticed that there is an increased risk of damage to the nerve. I think one has to be aware every time you lengthen someone that the nerve is at risk. And so therefore, it is very important that you protect the nerve. The other job that I do is to fix pelvic and acetabular fractures, and therefore I was always taught to be paranoid about the nerves. I keep the hip extended and the knee flexed. I generously release the gluteus maximus tendon if there is any tightness at all. I like to trace and mobilize the sciatic nerve at both ends, and then be very careful with retractors and instruments. And then you have to try and measure the length during surgery so you know how much you're lengthening. And these pictures show how the sciatic nerve has been identified and traced, releasing the gluteus maximus tendon from the femur, and then document your leg length before and after the trial reduction. And then that is the final X-ray of that patient with head grafts and with a screw at approximately 6 to 7 years. And most of the literature suggests that you can get a survivorship of approximately 80% at 15 years and 70 to 75% at 20 years. What about the femur? This can introduce a new degree of difficulty in planning the case, but not every case of a high dislocation or a Crow 4 needs a subtrochanteric shortening. In many of these cases, you can get away with good planning using a low neck cut, using appropriate soft tissue releases, and then sinking your cemented femoral stem slightly inside the femur so that you don't need a subtroch osteotomy. The other strategy is to bring the cup down, but not bring it all the way to the teardrop. We know from Pagnano's work that so long as it is the center of rotation is within 15 millimeters of what it should be, your results are almost like an anatomic hip center. So the term anatomic hip center is not an absolute measurement, but for me, it is a relative measurement. And by keeping 7 or 8 millimeters away from the teardrop, often you will get away without performing a subtrochanteric shortening. And again, this one has been reconstructed with a femoral head bone graft using a single cancellous screw. And you can see how well the screw has healed and the patient at 8 years follow-up. Another example of a high dislocation, this patient also had a bow to the femur and very odd morphology. A same philosophy has been used, avoiding shortening, femoral head bone graft, and a cemented short stem. We have these C-stems, which are called as Asian C-stems. We also have the small exeter stems on the shelf, and between the two, almost always we can get away without any custom stems. This was a case of spondyloepiphyseal dysplasia that I did. So dysplasia is not always part of congenital hip dislocation. It can happen in other pathologies as well. She had her spine fused and was very disabled. So these are cases where I would try and do a bilateral simultaneous procedure, which is quite rare in my practice. But in this case, this is what I've done: a bilateral simultaneous total hip replacement using acetabular bone grafting and a C-stem. And that is her follow-up at 4.5 years. So when do you do a subtrochanteric shortening? So in this case, this is the high dislocation on both sides, and we'll see how we can plan this. So the right side was done first with good planning, and we were prepared for a subtrochanteric osteotomy if needed. But during surgery, we did not need that. In this case, the bone stock was not really very good, and we were not confident that a femoral head graft will give reliable stability long term. So we preferred to use an augment. But when we went to do the other side, which is the left side, we realized that that is the one which will need a subtrochanteric osteotomy. So this is the technique to be used if you want to do a subtrochanteric osteotomy. You do a trial reduction first with your RASP or with your trial stems. And if it is too tight, and if you cannot reduce the hip because of soft tissue tension, then I would consider a subtrochanteric shortening. The osteotomy has to be performed in a biological manner. You have to try and make sure that you respect the periosteum. Plan your rotation meticulously by using an osteotome or a diathermy so that you know how much derotation element you want to introduce. The cuts should be parallel to each other so that you can optimize the bony contact. Then once you have done the osteotomy, the trial stem is inserted only in the proximal fragment, and then you do a reduction and then check how much overlap there is with the leg sitting in the natural degree of tension. And that degree of overlap is the length of segment that needs to be excised. And then you can wrap the segment around the osteotomy like Dr. Cameron used to do in Canada when I was doing my fellowship there, or you can crush it and use it as bone graft, or you can excise it completely. Then I stabilized the osteotomy with a 3.5 millimeter compression plate using unicortical screws and use intramedullary autograft so as to prevent the cement from extruding into the osteotomy. And then that's the technique, the early X-ray and the follow-up X-ray with a well-united osteotomy with a cemented stem. In this case, the acetabulum was very small, and it was so small that I could not even get a 38 by 22 polyethylene cup inside. And so I use an uncemented cup for these cases. These are bantam cups, and they go as low as 38. This is another case where an Esseron stem had been used in another hospital for a subtrochanteric shortening. This is probably the favorite stem for most surgeons when they do subtroch shortenings, but it is not without its own problems. You can see on the right hip, it has worked quite well, but on the left hip, unfortunately, there is a non-union and the stem has become loose. The canal was very narrow. So we had to plan a custom cemented stem, which goes longer, and associated with that, we had to do impaction grafting and then fix it with a plate as well. And you can see the follow-up at 2 years. So to summarize, what have I learned so far? These are very challenging cases. You do need meticulous preoperative planning. Luckily at Wrightington, I have access to a lot of senior people who have wisdom and who have done this before me. So we discuss these cases in our MDT, we make a plan. However difficult the case, there is always someone who has done it before you, and there is no harm in asking for advice. You need to consent and counsel these patients meticulously of the risks, of the need for further revisions. Treat the sciatic nerve with respect. Try and restore the anatomic center of rotation where possible. If there is no option, and if you have to use a high hip center, then it may be okay, but try and not lateralize it at least. Our philosophy is to restore the acetabular bone stock using a structural autograft, and I've shown you X-rays of follow-up. They work extremely well. And then selectively to use a femoral shortening when needed. So the philosophy is try and use the simplest option that does the job the first time. Thank you very much.